you. Let's go.
All right, good afternoon, everyone. Welcome to the March 1st joint hearing of the Budget and Tax Subcommittee on Health and Human Services and the Appropriations Health and Social Services Subcommittee. Again, I'm Melanie Griffith here with the House Chair, Krill Resnick, and members of both subcommittees. We have two budgets that we will hear today. We're going to start first with the budget of the Maryland Health Benefit Exchange, and we have as our analyst Tanya Zimmerman. So we will turn it over to Ms. Zimmerman to proceed.
Thank you, Madam Chair. The Maryland Health Benefit Exchange's budget increases by 1.9 million, or just under 0.5% in fiscal 2022 after you account for deficiency appropriations and other statewide actions. There is one proposed deficiency appropriation. It withdraws $88.6 million of special funds from the health insurance provider assessment that was intended to support the cost of the reinsurance program in fiscal 2021. These funds were unneeded to pay for the costs of the program in that year due to lower than expected payments. And so the withdrawal has no impact on the payments that were made for plan year 2019, which were already paid in fiscal 2021. In fact, the federal funds, federal pass-through funds that are remaining in the budget are more than were needed to pay for those costs by about $20 million. Overall, the reinsurance payments account for 83% of the fiscal 2022 budget. The next largest share are for IT contracts, and that's primarily for independent contractors that support enhancements and maintenance and operations and project management for IT activities. Exhibit 2 presents changes in the proposed budget. The largest increase is in the reinsurance payments, and it's based on the actuarial analysis of the 2020 program year costs. However, that increase of 4.7 million is really understated because the fiscal 2021 costs and payments were much lower than expected. So if you account for that, it would really be an increase of about $25 million. However, these are just estimated costs. We will not actually know the costs of the program for plan year 2020 until like June or July. The remainder of the budget has a variety of kind of puts and takes, resulting in a net decrease with increases associated with marketing and actuarial services and about $2 million worth of increases related to IT, primarily for those independent contractors based on at the estimated hourly rate for those contracts. In terms of the IT enhancements that are budgeted, there's about $10 million of funding for the IT enhancements in the budget. The agency identified about 29 enhancements. We've broken them down into a few categories. One being implementing policy changes and improvements in customer experience for Medicaid. Another is program improvements or policy changes. And that includes implementing the second phase of the Easy Enrollment Health Insurance Program, and to implement a state subsidy program, which is currently under legislative consideration. And another is consumer assistance, including enhancing options with additional like automated assistance and on-demand features. In terms of personnel, the one primary change here is that they eliminated some contractual FTE that were budgeted in fiscal 2021. Those are for paid internships, and that's primarily due to a decision to delay those paid internships until the remote work period ends. The other item to note is that they had 7 vacant positions as of December 31st. Excuse me. The agency indicates that as of February, it actually only has had 5 remaining vacancies. 2 of those, however, they were holding because they expected to use them for small business activities, and that's dependent on the availability of funding for those activities. So we've asked the agency to comment on the need for those positions if they don't proceed with enhancing the small business activities. The first key observation in the analysis is related to a proposal in the BFARA. Chapter 159 of 2013 established a distribution of the premium tax on health insurance for the operating funding for the health benefit exchange and mandated a minimum appropriation. Beginning in fiscal 2016, that was $35 million. Unlike other special funds, unspent funding from the health benefit exchange revert to the general fund. As shown in Exhibit 3, historically, the agency has not spent all of the level of funding that's been provided through the mandated appropriation. They indicate that's because of a conservative approach to budgeting for the call center contract. However, beginning in fiscal 2020, the General Assembly and the governor started taking action to reduce the level of spending within the agency with a reduction by the General Assembly in fiscal 2020 of $1 million, and then an additional revenue assumption made by the governor due to expected underspending. In fiscal 2021, the BFARA as introduced proposed a permanent $3 million reduction to the mandate. The General Assembly passed a reduction of a one-time reduction of $3.5 million, and also took a separate reduction. The BFARA of 2021 also proposes a permanent $3 million reduction to the mandate, but because of the higher reduction in fiscal 2021 than the BFARA has proposed, that actually results in a small increase in the special funds that are available to the agency, even with the mandate change that's proposed. However, the fiscal 2021 budget does not yet reflect any federal fund impact of the one-time mandate change in that year. So while the fiscal 2022 allowance includes a contingent reduction to account for that, as a result, the net impact is a decrease in the budget, even though there is the slight increase in the special funds between the 2 years. The agency currently plans to accommodate the entire mandate reduction within its call center contract. And the funding that would leave is only about 62% of their actual spending on that contract in fiscal 2020. And the agency indicates that would result in reduced service during periods outside of open enrollment. However, DLS notes that in fiscal 2021, the reduction was actually spread among various contracts, which would limit the impact in any one area. And as shown earlier, there were a number of increases to other activities in the budget while assuming the reduction in only this one area. Language in the fiscal 2021 budget bill restricted funds within the agency until they submitted a report on their long-term funding needs. The agency's response indicated that they would need $37.5 million, which is higher than the current mandated level. The increase would primarily support 23 additional positions, and it included an estimate for increased funding related to a number of other activities as well. And DLS notes that the agency's fiscal 2022 budget, accounting for the proposed mandate change, accommodates a number of those additional activities that were described. So the primary need would be the additional positions. DLS recommends releasing the restricted funds, and will write a letter to that effect if no objections are raised at this hearing. The second issue is related to the Reinsurance Program, which began in the 2019 plan year and has had a substantial impact in terms of lowering rates. However, because 2019 plan year was the first year of the program, there was a lot of uncertainty heading into the actual payment amount, about how much the actual payment amount would be. The initial actuarial analysis estimated $462 million. An analysis last year indicated that it would be considerably less. However, due to the uncertainty, the budget included the higher amount, which is what in part leads to the negative deficiency that I noted earlier. However, the actual payment level turned out to be lower than both of those estimates. It was about 17.5 million lower than the analysis last year, and more than $100 million lower than the initial estimate. Due to the lower actual payment level for the 2019 plan year, as well as the impact of COVID on medical utilization, the actuaries lowered the estimated payment amounts through the remainder of the waiver period in the most recent analysis. In total, for the remaining period, they lowered the estimated payments by $54 million. So the program was expected to be funded in two ways, which are federal pass-through funds, which are basically the foregone premium tax credit payments that wouldn't need to be made because of the lower rates, and a provider assessment, which goes till calendar 2023. It was higher in 2019, which is why we collected a higher amount. It was 2.75%, and then it went down to 1% for the remainder of the period. So the federal pass-through funds in the first 2 years of the program, we have actual figures for 2019 and 2020 were much higher than was expected. And that led the actuaries to forecast growth through the remainder of the forecast, the waiver period. And the costs then have turned out to be lower, or forecast to turn out to be lower because of the experience in 2019. As a result, the pass-through funds were expected to be more than were needed to cover the costs of the program through the waiver period. In fact, in the most recent actuarial analysis, they were estimated to exceed fairly significantly the amount of payments. And the provider assessment wasn't expected to be needed for the costs of the program at all. However, the 2021 estimate recently released by the Center for Medicare and Medicaid Services was considerably lower than what the actuary had estimated. So the actuary estimated over $500 million of federal pass-through funds, but CMS's recent estimate was $335 million, so more than $200 million less than what was forecast. The estimated excess pass-through costs from the 2019 and 2020 plan year amounts are expected to be sufficient to cover the costs of the program in 2021 without any provider assessment, but it seems likely that we will need funding from the provider assessment to support the program going forward, because it seems unlikely that this level of federal pass-through funds will be provided given what we have seen for 2021. Because it seemed that there would be the available provider assessment, the agency was asked to look at options for a state subsidy. And they released a report that provided a comparison of a number of different types of state subsidies targeting young adults and people earning over 400% of the federal poverty level. The work group recommended prioritizing a subsidy for young adults. And in the report, it was also recommended that if the legislature wishes to proceed with a state subsidy, that they should consider beginning with a pilot, and that there should be consideration about whether to apply for a state innovation waiver to enable the use of federal pass-through funding, and additional consideration about the future of the provider assessment, which, as I noted, is scheduled to end in calendar 2023. And there is legislation that would establish a pilot that's under consideration. The fiscal 2022 budget does include funding that the agency indicates is in part to expected to support the implementation of such a subsidy. The BFARA of 2021 proposes to use a total of $600 million of the provider assessment, $100 million in each fiscal 2021 through 2026 to support Medicaid. That's $200 million in the current budget through a deficiency appropriation and the fiscal 2022 budget itself. The collections certainly appear to be sufficient based on what we've already seen and having 3 years of funding left of these collections. However, given the recently much lower federal pass-through funding estimate for 2021, it is less certain that all $600 million would be available because it appears much more likely that we will need some funding to support the reinsurance program. DLS does recommend a technical correction to the BFARA, which is just to clarify that the transfer can occur from the fund balance rather than only new provider assessment revenue, and also to clarify who would make the transfer. And again, this does provide some risk to the reinsurance program because we are required to have funding to fully support the cost of the reinsurance program. And this is particularly likely as a result of the 2021 plan year estimated pass-through amounts, which were much lower than the forecast. It also raises some questions about what would happen after the current waiver ends. Now that, again, the agency has includes money, which it indicates is in part for an actuarial analysis that might be needed for a waiver extension. But if the waiver were to not be extended, what would happen, because this would have allowed funding for additional years for the program beyond the waiver period. And then unrelated to the reinsurance program, if the General Assembly wishes to pursue a state subsidy, you would have to consider how to use these provider assessment funds in terms of the availability of funding to support each. The final key observation, I'm not going to cover very much of this. I just want to highlight one thing. The number of individuals enrolled in qualified health plans was higher in 2021 than in any prior year. And there were two special enrollment periods that were available in 2020 that likely contributed to kind of this higher level of enrollment. And that includes the Easy Enrollment Health Insurance Program, which currently allows people to kind of check a box to indicate if they're interested in receiving information about health insurance options. It was expected to eventually translate into more of an automatic application process. It doesn't appear that is likely to happen, but they are moving forward with a more automated process, potentially a pre-populated application. And we've asked the agency to comment on the status of the implementation of that second phase. And then finally, I'll just go over a couple of the recommendations. The first is committee narrative that would just ask the agency to provide information or notification to you if they apply for any state innovation waivers or any extensions of the current waiver and what the decision on those applications are. The second is committee narrative asking for information on the reinsurance program costs and the forecast. And the final one is the recommendation to the BFARA, the technical correction that I mentioned earlier. And that concludes my presentation, and I'm happy to take any questions.
Thank you very much. That was a lot of information and well presented. Are there any questions from either of the committees? Hey, Mr. Chairman, I don't see any hands. Do you?
I do not.
Okay, well, that must mean thank you, Ms. Zimmerman. We are prepared to hear from Miss Michelle Eberly, who's the Executive Director, and I have Tony Armit.
Armiger.
Yes,
Yes.
ma'am.
Thank you. Good afternoon.
Good afternoon, Chair Griffith, Chair Resnick, and members of the subcommittee. I am Michelle Eberly, the Executive Director for the Maryland Health Benefit Exchange. And with me today is the Chair of our Board of Trustees, Secretary Dennis Schrader, and our Chief Financial Officer, Tony Armiger. I'd like to begin by thanking Tanya Zimmerman for her very thorough analysis of the Maryland Health Benefit Exchange budget. We appreciate her in-depth review that she's done now for several years and her understanding of our budget, which is complicated. Nearly 10 years ago, on April 12th, the Maryland Health Benefit Exchange Act of 2011 was signed into law, which established the Maryland Health Benefit Exchange. It is the mission of the exchange to provide affordable, accessible health insurance for all Marylanders. In our testimony submission this year, we reflect on the purpose of the exchange, the funding, performance, and respond to our analyst questions. While I will not go through each slide in detail, we present it for your reference. So I'm going to begin on slide 8. The exchange has 3 programs for budget purposes. Program 1, which is on slide 9, consists of our operational and administrative activities. This includes services such as marketing, printing, our call center, fulfillment, rent, utilities, staffing, and the like. Anything that is Medicaid reimbursable is funded at 44% with federal funds and 56% with state funds. Federal funds are secured by the Maryland Department of Health as a state Medicaid agency, and they're passed through to the exchange. The state match for any Medicaid-related work is provided through the exchange special fund from the premium assessment tax. All small business program activity, plan management, policy work, and related staffing are covered fully with state funds. They are not Medicaid related, so they require 100% of state funds. The fiscal year 21 state fund allocation is about $19.7 million. On slide 10, I provided an illustration for program 1, so you can see where the funding, how it applies. So for fiscal year 21, the call center cost allocation was $17.2 million. And you can see the funding source. There's a couple little different ways that it gets funded depending on eligibility or not. So I did include both of those. The federally funded portion for the Medicaid and MCHIP piece is $10.3 million. And that is what we draw down from CMS. Now, the state funded portion that's attributable to Medicaid and MCHIP is $4.8 million. And the state funded portion attributable to private commercial plans is $2 million. So that shows you how that division occurs. On slide 11, I'll now move on to program 2. So program 2 is all of our information technology. That's our software, our hardware, our system development, maintenance and operations, and our contract IT staff. And as you may recall, what's unique about the exchange is that we do all of our IT work in-house. So we found probably 4 years ago now, 4 or 5 years ago, when we pulled everything in-house, we saved millions of dollars by doing that and had much more nimbleness, much more ability to control the quality of the product. And that's worked very well for us. For our IT, anything that is Medicaid reimbursable is funded with 79% federal funds and 21% state funds. That's for development work. And then for maintenance and operations work, it's a 66 federal fund, 34% state fund split. Like program 1, the federal funds are secured by Maryland Department of Health and pass through to the exchange. And then the exchange fund picks up the state match for that as well. For fiscal year 21, that state fund allocation was $11.5 million. Moving on to slide 12 is Program 3. And Program 3, which is the largest source of funding, and the one we pay the least amount of attention to because it truly is just a pass-through of funding. It's a state reinsurance program. These funds at this time are restricted and can only be used for the reinsurance program. And so those are funds that when the carriers submit their claims, about 18 months after that, the start of that plan year, we will reimburse them for a certain percentage according to certain parameters. For the first 2 years of that program in 2019 and 2020, as Ms. Zimmerman had indicated, we received more than enough federal funds to pay for the program. That was our expectation according to our actuarial analysis for the continuation of the program, which is a 5-year program. We did just this past Thursday receive our estimated federal funding for this calendar year 21. And it is, as Ms. Zimmerman noted, significantly lower than what we had anticipated. Now, while it is lower than what we have anticipated with the leftover funding from 2019 and 2020, we will be able to pay for the 2021 program in full. That's our estimate. However, it does alert us to the fact that we will need to draw on the state assessment portion, which you heard about as we move into the next 3 years. Moving on to some of the work we've done, on slide 14, we'll show you a little bit about the individuals we've covered in health insurance. We've done a tremendous job. We're going on actually 10 years since we were created. We have the highest number of individual market enrollments to date, but we know that there still are about an equal number of people in this state that don't have individual health coverage. Now, one other thing that I want to point out to you, if you look on slide 15, the number of our consumer assisters around the state. We have everything from folks located at the Department of Social Services, the local health departments, our navigators, we are brokers, and that's actually one area that I want to make note of, our brokers. If you look at those numbers, you'll see on the chart on the left-hand side is the Medicaid enrollments, and on the right-hand side in the bottom is the commercial insurance enrollments. You can see on the left-hand side, our producer community does an awful lot of Medicaid enrollments, and they don't even get paid to do these. So we see oftentimes mixed households where a family will come in for health insurance. Mom and dad might be in a commercial plan where the children are an M-CHIP. So there's a lot of mixed households that we tend to. On slide 16, we hope to demonstrate the value of the work we do. Nearly 1.4 million Marylanders are enrolled through Maryland Health Connection. That's 23% of all Marylanders, over 1 in 5. If you just take our state 35 million, which is what it's at statutorily, that equates to $25 per person. So we're doing an awful lot of good work on that funding. On slide 17, I just want to point out some of the work we've been doing in response to COVID. We opened up a special enrollment period when Governor Hogan declared a state of emergency. We've had the longest special enrollment period in the nation. More than 130,000 Marylanders have enrolled through the special enrollment since it began last March, almost a year. We recently extended it until May 15th to be in line with the Biden administration new special enrollment period. And we still see on average about 200 people a day coming in looking for health insurance. So it's still very much needed in our state. And the other thing that's important that we relay to all of our consumers is that Maryland Health Connection covers the cost for coronavirus tests, doctor's office visits, urgent care visits, and emergency rooms. We've really seen a lot of folks feel the sense of comfort and peace of getting health care during this crazy time. If I can move on to slide 18 now, I do want to talk for a minute about the BFARA reduction, and this is the $3 million reduction. It is correct that since 2017, we have been operating underneath, below the mandated $35 million that was statutorily developed when we were established. What originally began, that was a very favorable contract negotiation we did with the call center. And the cost has primarily been under the call center where we've reduced. In addition to that contract negotiation, every year we have done significant technology improvement, which has directed folks away from the call center. So for instance, we've done robotic process automation, which allows the system to do work instead of people having to do it. We've done a chatbot feature, and we can tally up every month where we have nearly 3,000 calls that are handled by the chatbot. And those are calls that otherwise may have gone to the call center at $10 a pop. So we've done a lot to really lower those costs. In addition, I spoke about our producer community, and we have consumers that continue to go back to the producers. So again, that keeps calls from the call center. So therefore, we have determined that the $3 million in state funding with the related 4.1 federal match should come from the call center. We will monitor this closely, and should we find that there's significant service level disruptions, we have our local departments of social services, we have our local health departments, and we will also work with our state Medicaid agency if we need additional funding to work and see if there's other options for that. I do want to note on slide 19 that there are several pieces of legislation that will require work from the exchange that were not in the fiscal 22 budget. The Biden administration coronavirus relief package has an advanced premium tax credit increase. And so that will allow folks even over 400% of the federal poverty level to get tax credits, and it will expand it for those under. That will require additional work on our end that we had not anticipated. In addition, implementation of the Young Adult Subsidy Program, if that moves forward, the fiscal note, we estimated $290,000 for that. And finally, the implementation of the Easy Enrollment program with labor. If that moves forward, we estimate $359,000 for that. Finally, I would like to address the questions, recommendations, and narrative that was raised by Ms. Zimmerman in our budget analysis, and this begins on slide 22. So page 7 of the report requested that we address the vacant PINs related to the small business program. And if you look in, again, the beginning of the presentation, it talked about the key tenets of the exchange and why we were put together and the functions that we are here to do. And it includes providing health coverage for our small businesses. Not only do we provide health coverage, we also provide dental coverage as well. And that program has grown phenomenally over the years. So this is something that we are here to do. There was a particular reason why we didn't fill these PINs, and I like to say it was the trifecta. One, we had the $3 million budget reduction from state funds, and at that point it was state funds only. And the only place where we have state funds only, again, are those few programs like policy, plan management, and the small business program. In addition, there were several pieces of small business legislation that were going through the pipeline last year that did not get anywhere as the session ended early. And then third, that the governor froze PIN positions, and we fully supported that freeze on these positions because of the state of, we did not have any idea of what the finances for our state were going to be because of the pandemic. But it was that combination of three that had us make the decision to put the program on hold for a year. Now, although we did that, we are ready to get that program going again. So our PINs we've requested them to be unfrozen, and they are being unfrozen. We are working with key stakeholders around the state to implement enhanced small group program. We were able to get some of it into our system already, but we are still working on that. So therefore, we will fill these 2 pins, and we have plans to get that started in March, April timeframe to fill them. Second, I want to address the timeline for determining whether to submit an application for the extension of the waiver and when such an application would be submitted. And there's 2 things here that we need to keep in mind. So we could either just extend the existing waiver we have, and that has one timeline. And that timeline you'll see is spelled out where we really would start the work January, April of 22, based on the General Assembly's determination whether to extend the 1% state premium assessment. And it would go through January 2023 when we would submit the waiver application and work with CMS to get it approved for a January 1st, 2024 5-year cycle. So that's one scenario. The second scenario on the next slide is if we determined that we wanted to modify the current waiver we have. So in this case, if we wanted to include some funding for the individual subsidy program. If that's the case, we'd have to start a little earlier because the federal government requires that we send a letter of intent at least 15 months prior. And so there's more time that we need to get this one before our federal partners. So that again would start January to April 2022. And then we would have to submit our application for this one by February of 2023, and by September 2022, submit the letter of intent. So there's more steps to this, again, for the same target date of January 1, 2024. And then the final item that was asked to provide comment on was the status of implementation efforts on the second phase for the Easy Enrollment Program. And as Ms. Zimmerman stated originally, we had hoped to be able to have anyone who applied or checked that box through the controller's office to be able to just be automatically enrolled. Unfortunately, Medicaid restrictions, federal restrictions, will not allow us to do that because of the way we have to check things such as citizenship. So what we are going to do instead is take all that information and pre-populate a form and get it closer to that automatic renewal. That's all on track. We have a committee that's meeting while the technical requirements are underway. We are on track for that for the 2022 tax filing year. Now, what we've done with the tax enrollment folks since we started last year, when people checked the box and we got their information, we reached out to them in 3 different fashions. We sent them electronic notice, we sent them postcards, and I think we had, a special enrollment notice. So there's 3 different ways that we reached out to them with paper. Then when it came time for open enrollment, if they had not already enrolled, we reached out to them again, saying, okay, now it's open enrollment time. You can come back now and enroll at this time. What we will be doing in this next cycle as we start to get the files from the controller's office is now we're going to also, in addition to those other methods, we're going to use our navigators to reach out personally to individuals. So that we know that the best way, successful way of getting someone enrolled is to have that one-on-one connection with them, whether it's a family member or a navigator, to really help them and guide them through the process. So that's the next step we'll be doing this year. And then in terms of the recommendations on the report, page 10 and page 16, the release of the $450,000 in special funds and the technical correction, the exchange concurs with those. It's not, we don't have any problem with either of those. And then on page 22, the notification of applications for state innovation waivers and decisions on those within 20 days, reporting that. and the Reinsurance Program reporting on that with a new actuarial analysis, we concur with those as well. So with that, I will conclude my testimony, and I am happy to take any questions from the committee.
Thank you very much for your presentation and your responses. Are there any questions from the subcommittee members? I see Senator Rosa Pepp, followed by Delegate Valentino Smith.
I finally showed up again. My apologies, Madam Chair.
No problem.
I do have a question. You were talking earlier about the number of mixed families where somebody gets Medicaid and somebody gets a subsidized plan and somebody gets the children's thing. Approximately how many families are there like that? Is that like 2 families or 200,000 families?
Well, when we had looked at it before, I believe out of our, and I can get you exact numbers, but I believe out of the 150,000, we had 20,000 that had a mixed household.
20,000 people who were in a mixed household, so the number of households was smaller.
I believe that's the case, but I can get you that information.
I got you. Is there any either reason why that's a problem for them or for you, or is there any solution to try to integrate people in families better with their coverage?
No, it's not a problem at all. And that's the whole concept between Maryland Health Connection, where you have the family come and we can route them in whatever, to whatever health plan and health coverage that is best for them. That's the whole concept behind what we're doing.
Okay, I just wanted to clarify that. Thank you, Madam Chair.
Thank you, Mr. Vice Chair. Vice Chair of the Subcommittee, Delegate Valentino Smith.
Thank you, Madam Chair. I had 2 questions, and thank you, Ms. Eberly, for the detailed report. One, I'm a little confused. On page 9 of the analysis, when you talk about the call center report, it says that Maryland Health Benefit Exchange indicates that this reduction would result in reduced services during periods outside of the open enrollment period, leading to longer wait times and an increase in abandoned calls and referrals for Medicaid-related questions then would go to the local health departments. And they, of course, are on overload now because of COVID and the pandemic. So, but then in the report that you gave us, you said you were no longer concerned about the cut to the call center, and that confused me.
So we are concerned about any impact that it might have on service levels. Why we're not as concerned as we have been in years past is that the funding for the call center, we have been running under. And
Right
again,
now.
this year we see it running under. So I think and again, it's always a moving target because things, for instance, the Medicaid redeterminations have been on hold for a whole year. So when those come back, we may have an influx in calls. So it's always a little moving target, but we think that we can probably handle it. And if we can't, I've already talked with our partners at Maryland Department of Health to see if there's some other way we could look at shoring up some of that funding if needed.
I mean, I just think given what we've seen going on at the local health departments, I don't feel comfortable relying on you shifting the calls there for those that need help. The second question I had was, the report glowingly talks about a lot of the increases in enrollment for Medicaid and for other populations, and you even gave a chart on the decreases that you're seeing in the premium rates. We're still seeing a really exorbitant high number and continued increasing rate for infant mortality. And so we're starting to be concerned or wonder what the coverage is for pregnant women, and or if they have coverage, are they actually getting services once they're covered? So I don't know that it might be too long to answer now, but I think we'd like to work with you a little bit more to figure out why that particular population is continuing to increase with respect to infant mortality if we're getting more coverage to our at-risk populations.
We're happy to work with you however best we can. We work with our carrier partners and our MCOs on coverage that they provide. We do know at the exchange that is a very big area of public health that Maryland Department of Health is looking at. And so We are available through being able to do communications to all the members that come through our system as a partner to anything that's going on, but we'd love to have more discussion on how we could help with that.
Thank you. Thank you, Madam Chair.
Thank you. Are there any other questions from the committee? Okay, I want to thank you again. Ms. Eberly, I just want to sort of follow up on the Delegate Valentino Smith's point as it pertains to the call center, and just say that I believe that several members of the subcommittee share that concern, particularly as re-enrollment becomes an issue again. And I did note, I was very interested when you talked about the technology that you're working on in the chat. Did you say chat bot?
Chatbot, yes.
Yeah.
It's a feature we have already today.
Right. And but one of the things that would concern me is on your slide, and I didn't mark which one, I think it was slide 10, you talked about if there are issues with Medicaid, they would be referred to other agencies. DSS, I think, was one that you named, and others. And like the delegate, I would be concerned about the bandwidth of those agencies if there's a surge. You all are doing a great job in marketing and reaching out to the folks that are in need of coverage. And so just wanted to share that, echo that concern about the call center and any reductions there. I don't see any other questions from the committee for this panel. Okay, so thank you very much. We do have several witnesses that have signed up to testify on this budget. So we will turn to Tony Torsch, followed by Allison Taylor, and then Jennifer Breman. So Tony Torsch, you can proceed. If you were here, I thought I saw that name pop up earlier. Okay, maybe they've dropped. So if they come back, we'll keep an eye out. Do you see them, Mr. Chair? Nope. Okay, so we'll move on then to Allison Taylor. I see her.
Hi, good afternoon, Madam Chair, Mr. Chair, members of the subcommittees. My name is Allison Taylor, and I'm here on behalf of Kaiser Permanente. We provide care and coverage for 450,000 Marylanders, including those served by the exchange through their individual and small group markets and through Medicaid. So I wanted to raise a couple of concerns about the budget. The first relates to the very, very large budget transfers over the next 5 years out of the reinsurance program to Medicaid. As has been noted both by Ms. Zimmerman and by Ms. Eberly, this program has been very, very effective, both at reducing premiums for individuals in the individual market, and also for increasing enrollment in the individual market. It's become increasingly important through the pandemic as we're seeing a lot of people who are losing employment and thus are losing their employer-provided healthcare coverage, and so would be seeking enrollment through the individual market. And as Ms. Eberly noted, they've had a special enrollment period open since last March in order to do that. It does sound like there's been some new information that's come out very recently, as noted in the previous presentations, that it's less certain that all $600 million that would be required for this transfer would be available. It sounds like there's even some information coming out from the federal government as recently as last week, indicating that the provider assessment funds could potentially be needed. So we think it would be more prudent for the committee to proceed with caution in this area, given the possibility that this could disrupt the reinsurance program. And especially since it's projecting out through 2026. So that's one point. The other goes to the exchange's operating budget. We share the concerns about the call center and want to make sure that it is as efficient as possible for Medicaid enrollees and those in the individual small group markets as well. And just generally, as Ms. Everly noted, there's going to be some new work for them to undertake this year. We're seeing a lot of movement from the Biden administration at the federal level with changes like Ms. Everly has noted that will require more work from them. Just given the market dynamics and the real need to make sure people have coverage, we would urge against a cut to their operating budget. And that's it.
Okay, thank you. And Jennifer Breman.
Hi, good afternoon, Madam Chair, distinguished members of the subcommittee. Thank you for the opportunity to speak with you today. My name is Jennifer Breman. I come before you representing the Maryland Managed Care Organization Association. MMCOA represents the 9 managed care organizations that serve 1.3 million Marylanders enrolled in the Health Choice program. As you will read in our submitted written testimony, the MCOs share the concerns outlined in the budget analysis on page 9 regarding reduced funds going to the Exchange Call Center. We agree that cuts to this contract funding will lead to an increase in abandoned calls and Medicaid-related questions and requests not being fulfilled, which will result in losing possible Medicaid-eligible enrollees during a time of increased need for this service. With the sharp growth in Medicaid enrollment since the onset of the COVID-19 pandemic, the Exchange Call Center has played a critical role in transitioning individuals to Medicaid enrollment and coverage by an MCO. According to the statement issued by the Maryland Health Benefit Exchange in December of 2020, and included with our written testimony, 2/3 of new enrollees through the exchange during the public health emergency were Medicaid enrollments. Any reduction to the operating budget of the call center is of great concern to the MCOs and the members that we serve. This decrease in funding may impede timely enrollment and access to care for Health Choice eligible individuals. We respectfully request that, especially during this time of increasing Health Choice enrollment due to the hardships linked to the COVID-19 pandemic, funding to the call center is not reduced. As always, the MCOs look forward to continued collaboration with the state as we work to identify ways to improve access to affordable, high-quality care for all Medicaid participants. Thanks so much for your time.
Thank you very much. Are there any questions for Ms. Taylor or Ms. Breman? Okay, seeing none, I see no further questions from the subcommittees. So thank you all very much for your testimony and for sharing information with us this afternoon. That will conclude the budget hearing for the Maryland Health Benefits Exchange. We'll now turn to the MDH Behavioral Health Administration, and we will hear from analyst Andrew Garrison. Good afternoon.
Good afternoon, Madam Chair, members of the committee, the subcommittees. I'm going to be sharing my screen here for the Behavioral Health Administration budget. Can you all see that? Awesome. So this is the budget for the Behavioral Health Administration. We have a $2.4 billion budget in front of you, and a lot of that is from provider reimbursements through the Medicaid program for Medicaid enrollees for fee-for-services on the behavioral health side, so largely specialty mental health and substance use disorder treatment. First, I want to highlight the individuals that are served in the public behavioral health system. So this is going to be looking back at the last 5 fiscal years. The most recent actuals are actually showing a decrease in the number of individuals served over the 19 period, while substance use continues to increase. On balance, the total number of individuals served did decrease. We would anticipate that this is less of a particular need, but rather perhaps some interruptions in service due to COVID-19 and individuals accessing treatment there. The other thing, in this section of the analysis, we discuss performance measures. However, due to the ASO transition, which we'll talk about a lot more later, some of those measures that we have not, that we've traditionally used are not available. And last year in the Joint Chairman's report, there was a piece of narrative around types of different performance measures that could be used both to assess the quality of the entire public behavioral health system, as well as the individual providers. And that was submitted. However, some of those measures highlighted required the ASO themselves to develop some of these new measures. And so we are asking the department to comment on when some of those measures would be available. Also, that report was silent on some of the individual provider quality items that DLS was interested in. And so we're asking them to comment on possibilities there as well. Moving into the dollars in this budget. First, we're actually going to start in fiscal 2020. So at the end of each fiscal year, when they're closing out the fiscal year, what the department does is they accrue total funds. We particularly focus on the general fund accrual for claims that have yet to be that were done in service year 20, in this case, the prior service year, but haven't been submitted yet. A claim can be paid within a year of that service. And so we do expect some claims to trickle in even after fiscal year closeout. Normally, the number that's accrued is fairly low from a general fund standpoint. In fiscals 19, 18, and 17, it was all below $20 million. This year, when closing out 20, the department actually accrued $117 million in general funds, about $100 million more than they traditionally do. Normally, by this time in the year, through this accrual process, we would expect about 90% of the amount of those outstanding claims to have already been booked. But also against this accrual is some of those underpayments from the ASO for service year 20. And so, which is accounting for the much larger accrual and sort of the continuing spend down against that. However, DLS believes that even if spending continues on its current trajectory, which is pretty aggressive, there would still be a surplus against that $117 million. So we are recommending a BFARA provision to recognize that reversion of at least $5 million, which we expect to be there by the time the accrual is fully expended. Into fiscal 21 now, the department had several deficiencies in this budget. The first of which at the top there is the introduction of the second round of state opioid response funding. This is going to be $50 million, 2 installments of $50 million, split between the Behavioral Health Administration and the Public Health Administration. The public health side has the more preventative measures. And so this is some of those early dollars there. Coming in as a deficiency. They're also there again in fiscal 22. The next item is the governor's fund swap for the enhanced federal fund match. Under federal legislation, the Families First Coronavirus Response Act had increased the federal fund match on certain Medicaid beneficiaries. And so because of that, the increased federal dollars going into the Medicaid program, we have about $60 million in federal fund and general fund savings in fiscal 21 that was shown as a deficiency. And then also the governor accelerated the provider rates that were due in fiscal 22 to begin in January 1 of this year at a total fund value of $23.4 million. Now we can look at the 22 budget that's in front of you all. As mentioned at the top, most of the dollar amount here is in provider reimbursements for those specialty mental health services. We have the Medicaid components, those two larger pies there are taking up about 75% of this budget. And then additionally, we have other services for Medicaid beneficiaries that that don't have a federal fund component to them, adding that other little bit. And we've also separated out those provider rates there. So in total, that is 88% of the $2.4 billion in front of y'all today. Focusing in on the non-fee-for-service side, here in Exhibit 5, we show that a lot of that other money in the budget, that remaining 12%, is also going towards different service treatments. So we have federal grants, including those state opioid response grants that I mentioned. We have mental health grants as well in here, again, federal dollars. We also have general funds that go to core service agencies or the local health departments in providing different types of special mental health services. And really, of this entire budget, we only have a fairly small share, under $50 million, that is administrative in nature, over half of which is that administrative service organization contract that we'll be discussing. From the budget change, a lot of this is provider reimbursements, which we will talk about a lot more in depth. Overall, we are seeing an increase of $181 million. But a few things that I do want to point out, My colleague Tanya previously in the Social Services Administration hearing discussed the Interagency Hospital Overstays Initiative. That money is showing up here as new money at $5 million towards the bottom of our screen here. We do also have state opioid response grant dollars. Because that deficiency came in fiscal 21, it's showing as a decrease in this year's budget, but ultimately we are expecting that SOAR money to be stretched out. On provider reimbursements, what we like to do in this budget is look at general fund and total fund adequacy to make sure that the amount that is in the budget is enough to cover what we would expect to be spent on provider reimbursements. This is more challenging. This is always a challenging process for us, but it was more challenging this year given the data from the Administrative Services Organization. So what I've done on Exhibit 7 here is I've looked at the December 2019 report that we use to calculate fund adequacy that we get from the departments. And that was the last one under the prior ASO. So something that we would traditionally use to build our forecasts off of. And then what I did is I grabbed the most recent report that they've given us in fiscal 21. I've labeled that with the new ASO. And what you can see between those two numbers is that's about a $200 million difference. And we certainly don't directionally expect that this budget is overfunded by, perhaps a quarter of the total funds. We do anticipate, of course, that there has been some decrease in service utilization, but also on the flip side, enrollment has continued to increase because of the federal Families First Coronavirus Response Act. And so it's just, while directionally there probably is enough money to cover fiscal 21 services, we certainly don't think it is the degree to which our current reporting from the ASO is showing us. So we're assuming general fund adequacy in 22 and 21 rather. Last year, as in there's language included in this budget that would restrict any moving of surplus funds from the Behavioral Health Administration budget to other budgets within the health department. So even if this is overfunded to the degree that's suggested currently, that funding would stay within behavioral health services or revert back to the general fund. For fiscal 22 adequacy now, again, on the provider reimbursement side, this is looking at the spending in the Medicaid program, which is that largest share of the total behavioral health dollars. And what I'm showing you here is the first part is what the Governor's Budget Office forecasts. And then the next column over is what our forecast was here. And our forecast is a little bit higher in part because our enrollment is a little bit higher. And that's because the enhanced federal match has been announced to extend it for at least 6 months of fiscal 22. That increased our enrollment a little bit because in order to receive that federal match, we can't do redeterminations. And so we're keeping people on the program a little bit longer than the governor was perhaps forecasting back when they submitted the budget. However, because that is also extended, we are continuing that increased federal fund match into fiscal 22, which was also not planned in this budget. And so if you compare the first column, that allowance column, to our projection after considering the enhanced federal funds, we're showing a surplus of about $35 million in general funds because of that extension of the enhanced federal fund match. So we do have a reduction in this budget of $35 million, at least because of that 6 months of the enhanced match. Another item here on the budget is highlighting just that SOAR funding and really just showing that that first round of SOAR funding has stretched into several fiscal years. And while the second rounds of SOAR funding have both entered the budget in the 21 deficiency and here again in fiscal 22, we would ultimately expect that to be stretched into several fiscal years as well, at least fiscal 23, given an even spend of what's been distributed so far. Last item on the dollars and cents of this budget is, if you recall, back in one of the first budget hearings that you all had, DLS recommended a fund balance transfer from the Board of Psychologists to the Behavioral Health Administration and for some general fund savings. And so we do have a contingent reduction here corresponding to that surplus fund balance transfer that we proposed earlier in this session. Moving on to the issues discussion of our analysis. The first one is discussing the Administrative Service Organization, that transition, as well as the estimated payments process and that going forward. And just first, before we get too far into this, I do want to put a signpost down for what we are talking about here is the overpayments. And so this is back in January of last year, the department issued estimated payments for what ultimately ended up being a 30-week period going into August of 2020. Of course, now we know that that 30-week period included, most of it was underneath the coronavirus pandemic and certain emergency orders. And so because of that, some services were interrupted, as well as other people having challenges accessing services. And obviously things looked a lot different by the end of that estimated payments period than they did at the beginning. And so while that estimated payments period was occurring, the providers were still submitting claims for services that they did. And the difference between the estimated payments and the what was actually submitted as claims, if what the claim balance was lower, then that's something we'd consider an overpayments. If the claim balance was higher, then that would be considered an underpayments. The department presented to you all back in November and submitted a JCR report sort of at the early stages of the end of this estimated payments period. And what that report did was it looked at a total value of overpayments, so money that providers owed the department, valued at $225 million roughly at that point, against a total value of underpayments, or what the department owed out to the provider community, which was about $62 million. Those numbers were then offset to get a net value of $163 million, which has been talked about quite a bit. What we were able to do with the data that the department provided us, because in practice these payments are really continuing on two separate tracks, what we're just looking at here is just the overpayments. So really just the difference between the estimated payments and claims were submitted when those claims submitted ultimately equaled an amount lower than what the department gave out during that 30-week period. So and that number is $300 million in the data that we looked at. The data was provided to us current as of February 1 of this year, which is again about $75 billion higher than what it was initially when we kind of first started looking at this back at that JCR in November. So with all that being said, first Exhibit 10 here, we have an overview of sort of the total amounts owed. How this data was presented to DLS was each individual observation. We had 2,600 of them, a little bit over that, where they were grouped by the tax ID code. And each one of those individual lines were blinded. And in that line included what sort of services or provider types that individual provider was doing. So each one of those observations was a provider, and some of those providers operated multiple different types of services therein. And so what we did first, once we got this data, is we lined up all of the providers by amounts owed, and we summed up the cumulative dollar amounts from the first to the very last. And we plotted that here for y'all on Exhibit 10. And what you can see is that a fairly small group of providers actually owe the department the largest share of the dollars. So by the time we get to the 100th provider, we're well over half of the dollar amounts that's ultimately owed to the department. And so it is not, this is not to say that the $300 million owed across 2,000 some odd providers is not a function of 300 million divided by 2,000. Rather, it is distributionally skewed towards some larger providers. Because the data is grouped by these provider types, we don't exactly know which services are accruing the most dollar amounts owed, but we do have, the sample had about 75% of the total providers in our data set just had one provider type associated with them. So it was really easy for us to match up this dollar amount to this service type. And we kind of call those individual providers for this discussion. And so we ran that same exercise with those individual providers. Although they're 75% of the sample, they're actually only about a third of the dollars amounts owed. And so we're looking at about a third of that total money. It's about $100 million. But again, this also follows that same sort of distributional scheme that we showed above, where even just these kind of one provider types, still much of the money owed is concentrated in a handful of larger providers. Interestingly enough, if you look at this half of the amount owed there, those 58 providers, DLS was able to identify that 16 of those were psychiatric rehabilitation providers, or PRPs, and that of these single provider groups, again, where we could point directly towards a service that was accounting for all of that amount owed, PRPs also owed the most there. They owe about $20 million. and that's twice that of the next provider type in there, which are drug clinics. And that's also true when we zoom back out and again, look at that big sample of providers with multiple different types associated with it. What we're doing in Exhibit 12, while we are double counting some dollars that are associated for a provider who'd be, for instance, running both a PRP and a mental health clinic, we still see again that the PRP providers are in some way associated with over half of the dollars that is currently owed by the department as reported to us. PRPs have actually been a fairly long-standing concern of DLS, particularly given some of the gross in enrollment and expenditures that we've seen in recent years. So much so that there was a budget bill language last year that requested a report on PRPs and the increase in PRP expenditures. That report has yet to be submitted. And so given that report is still outstanding, but also their prevalence sort of throughout this analysis when we were looking at the amounts of overpayments that are owed to providers, we are recommending the department submit a report on PRPs, and particularly if there has been any steps that have been taken to address some of DLS's pre-existing concerns, because any sort of systematic impact on PRPs that may have already occurred could be explaining this distributional impact, this uneven distribution of PRPs owing much more than any other provider type. Additionally, one other analysis we did here with this data set is we looked at essentially the distribution of dollars by who has paid off what at this point. So we've looked at what we did here is we took the total amount outstanding, their overpayments, and divided by the total estimated payments amount that they had received over that 30-week period. And so if you're a provider grouped on that 0% side, you've been able to match up all of your claims against the estimated payments and you no longer owe the department anything. If you're on the 100% side, you have yet to been able to submit a claim against your entire estimated payments and you owe the department the entire balance of your estimated payments. And while that extreme has 420 providers in it, they actually don't account for that many dollars. It's only $22 million or so. And really where we see most of the amounts owed when we're looking at the providers through this distribution is those folks there in that 20 to 30% range. So individuals who are still doing services and still submitting claims, but are likely larger providers where a downturn in utilization really does have a large dollar value impact. And that's what we're showing here on Exhibit 13. So summing up all of that reconciliation discussion, certainly given that it's a moving target and there are a lot of facets into both this data and how it can be interpreted, we are asking for recommending budget bill language, restricting $1 million from the Secretary's budget, pending a report on this reconciliation process. In particular, we're interested in any support or assistance that was given to providers to help with this reconciliation process, what sort of reporting has been made available to them. Of course, there's a lot of different reasons why someone may have resulted in an overpayment, none the least of which is some changes in service utilization due to the pandemic. And so we are looking to get a better understanding of what that process looks like. It is slated to be a 6-month process that would end in May of 21. Before I move on entirely from the ASO, there are still reports of challenges with the system since it has gone live back in August. And given some of these ongoing concerns, we are recommending committee narrative that tracks sort of the progress of the ASO's functionality from going forward. And so what this is requesting is the first report, which would be due on July 1, 21, would be to have the department, the ASO and the providers figure out what exactly is required for a functioning ASO for the provider community. And then subsequent reports having the department report on what progress has been made to meet those requirements. And if those aren't currently met, what steps and what would be an estimated timeline to have those particular aspects of a functioning ASO to be met. We're recommending that those reports be submitted quarterly or until full functionality of the ASO has been achieved. That wraps up our ASO discussion. The other issue that we highlight in this exhibit is the opioid crisis with substance use disorder services being a large part of this budget. The pandemic, of course, has a lot of risk factors associated with it that likely further exacerbate the opioid crisis. But first, to put into context really where Maryland is relative to the rest of the country, what we have here is CDC data for the 12-month period ending in June 2020. And we have plotted all the states with data reporting both the total number of opioid overdoses, and so that's on your x-axis, as well as the rates of opioid doses on a per resident basis. And what you can see sort of working from the top or the right-hand side of either is that Maryland ranks really high in both of those. They're the fourth we're the fourth highest state in terms of a total rate of opioid fatalities, as well as the sixth highest in total number. But interestingly, higher than some much larger states. I've labeled both Texas and New York there, which have a lower number of absolute opioid overdoses than the state of Maryland does. And what we see when we look at the data from the Opioid Operational Command Center, this is currently using data from January to September of calendar years, and we've compared those quarterly, those Q3 reports in each of the last 5 years here in front of you in Exhibit 15. And what we show, you might remember last year that calendar 19 actually saw a slight downtick in overdose fatalities, both total overdose fatalities as well as opioid-related overdose fatalities. And it seems that unfortunately so far in 2020, that trend is reversing, while other trends remaining consistent, such as a continuing prevalence of fentanyl and a decreasing prevalence in heroin. When we look at this same set of data, but on a regional standpoint, we're showing again those same trends with prevalence here, but there's a few regional aspects I do want to highlight. The green bar towards the center of the screen, that is Baltimore City alone, which individually consistently accounts for the plurality of overdose fatalities in the state, as well, and more so than the red bar below it, which is the 5 surrounding counties. But what is, I'd say, particularly interesting or troubling about the data this year is that the increases that we're seeing over 2019 are not just concentrated in Baltimore City, but it really is a statewide challenge, with all but 6 jurisdictions having an increase in overdose fatalities over where they were at this point in 2019. There's a small handful that are showing slight decreases, but that's certainly not been enough to offset the increases that we're seeing elsewhere. And I would say what's particularly interesting is drawing your attention towards Prince George's County, as well as several counties on the Eastern Shore. These counties are unfortunately actually already above where they were throughout the entire calendar year of 2019. And so what we've plotted here for you on Exhibit 18 shows where they were throughout all of 2019, and then where they are currently and how much that is additionally above where they were over that period in 2019. And as you can see, Prince George's County is fairly common, is there, as well as several counties on the Eastern Shore. Taken together as a region, actually, the entire Eastern Shore has experienced more opioid fatalities to date in 2020, or to date of the reporting data, than they did in all of 2019. Several of the reasons for that, as mentioned, the pandemic has likely compounded any sort of economic anxiety or stress or social isolation that would likely contribute to an overdose fatality. But one other possible factor is perhaps service interruption. And while the scope of the change in utilization seen across the public behavioral health system is still hard to determine due to the ASO, we were able to get separate data on substance use residential treatment. And what you see here is that really right after the state of emergency and a lot of the restrictions taken during the pandemic, residential services dropped off pretty quickly. However, at least for the non-specialty services, that larger blue section, they rebounded quite quickly, while some of the other specialty populations have yet to rebound. And we highlight that here in Exhibit 20, where we compare 1 month of 2020 to the prior month in 2019. Later in the summer, we have non-specialty increasing or rebounding to the 2020 levels, or to 2019 levels rather. But 8507s, those court orders, as well as the pregnant women have yet to rebound to prior levels of services. Of course, 8507s are not only dealing with some of the other challenges that residential providers are dealing with more broadly, but also any slowdown from the court side has impacted their admission ability and the number of patients that they're able to serve. They did receive support of $5 million in the Relief Act that you already passed this session. Lastly, while most of this discussion was on the opioid crisis, because that is the data that's available to us, we do know that a lot of those risk factors that are areas of concern for an increase in overdose are also likely contributing to a mental health crisis. That data does lag more so than the opioid data does at this point, but we do have some data from call centers. For instance, here we're showing the Here to Help hotline. This is run by the folks at Behavioral Health Systems Baltimore, and it's focused on mental health in particular for that Baltimore region. And they have seen an increase of call volumes really in excess of 50% in any given month when compared to 2019, which is what we're showing here. And so while we still don't necessarily know the full impact of the pandemic on Marylanders' mental health, we would anticipate that this is going to continue to weigh on individuals as well and create another and further contribute to some of the mental health needs in the state. Just to quickly recap the recommendations that we made in all of that, we do have that language here around the assisted reconciliation process from the ASO. We do also have then the language recommendation on the psychiatric rehabilitation programs in particular. We also have annual language, as I mentioned, that prior fiscal year dollars cannot be moved outside of the behavioral, the BHA budget. This is that language again this year. We have that contingent reduction from the transfer from the State Board of Psychologists. We have annual language. We do have that $35 million reduction again. We have that ongoing report on the ASO. And then we do also have that fiscal 20 recommendation of the $5 million in general funds. That concludes my presentation, and I'd be happy to take any questions.
Thank you very much. We've had a lot of information this afternoon. Mr. Chairman?
Thank you, Madam Chair. Andrew, thank you for that very thorough presentation. I have a question about the ASO payments that you presented. By the look of it, we're somewhere around 300 million or so for the money that has potentially been paid out and owed back. We're looking at, that doesn't even count the money that's underpayment. And we know of a number of providers at this point that haven't even begun to bill because of all the issues with the interface with Optum. It sounds like, and we were briefed on this, I believe it was November, if I recall, our committees were briefed on this with HGO, and we're told that things were improving and that Optum was getting everything back in order. It sounds like things have gotten worse in the last 4 months or so. Can you comment on that? I mean, does it look like it's getting better? Are things evening out, or do the numbers play out and it sounds like it's getting worse?
Thank you for the question, Chair Resnick. So I would say, without necessarily being able to comment on the provider experience ongoing with the system, I will say that it was curious to me that the number of overpayments that we were working with had gone up from November to the February data. When I was looking at that report in November, I assumed that it was directionally right, but ultimately, perhaps as more payments came in and more claims got reconciled, that number would go down. Of course, as I mentioned, we went from 225 million to 300 million in a 4-month period, while of course the total amount that was given out as estimated payments did not change.
Just as a follow-up, correct me if I'm wrong. If I'm remembering this wrong, then I'm remembering this wrong. But if I recall, the advance payments ended sometime mid last year, right?
August.
So if the advance payments ended in August, that's 8 months ago or so, 7 months ago. How are the overpayments still going up when we were told specifically by the folks at Optum that their payment accuracy, and this was, if I recall, last session during the budget hearing, their payment accuracy was in like the 90-something percentile?
Yes, the estimated payment number itself hasn't necessarily changed, but I would say that how the math would have to work in order for the overpayment amount to go up would be that claims that were perceived to be approved back in November have no longer been approved, or there's been some other movement in there. And I believe Optum's here with us today. They might be able to better comment on exactly how that movement occurred.
Okay, thank you, Madam Chair. I'd love to hear that when Optum is presenting, if Optum is presenting.
Thank you, Mr. Chair. Any other questions for Mr. Garrison? Okay, seeing none, we have been joined by Secretary Schrader. Good afternoon, Mr. Secretary. I don't know if you wanted to begin or Dr. Jones, Deputy Secretary. I can let you just lead off and introduce the panel if you like.
That would be great, Madam Chairman. Thank you. I'm joined here by Dr. Aaliyah Jones, our Deputy Secretary for Behavioral Health, our CFO, Jordan Butler. And in addition, we have available for questions Chad Burkholder, who's the Chief Operating Officer of Optum. He can field many of the detailed questions. We also have Corey Carpenter and Marianne Katsarelis, who are with us. So I'm going to, I just wanted to make 2 points. A year ago when we were here, the system was not operational. We determined at that time, myself and Secretary Neal, that we needed to go to keep the providers at least whole, and went to the estimated payments. And our philosophy at the time was to err on the side of the providers. So there is probably more money than might have been thought of in billing, but we wanted to make sure that we kept the providers whole. We are now in that reconciliation process and making progress. Our next step is to, and I thought the analysts did a terrific job of laying out the issues. We want to get an accounting firm to help us so that there's an independent third party helping with the next stage of the reconciliation, because some, almost 900 providers, as you saw, have very small amounts in question. And many of the providers make a very good point that, they don't feel like they should have to spend resources and time doing this analysis when they're small, and we agree with that. So we're looking at a way to provide that. And then, of course, as the analyst mentioned, a lot of the money, a very large percent of the money is with a smaller percent of the providers, and we're looking at how to do that best. So, and lastly, we are working very closely on getting the system fixes. Right now, we pay out what are the historical averages, $30 to $35 million a week, and that was in line with what the prior provider was paying, but or ASO was paying. I'm sorry, but we do have some changes that still need to be made to make the system more user friendly. So I'll stop there and turn it over to Dr. Jones.
Okay.
Thank you. Good afternoon, and thank you all. The Behavioral Health Administration continues to work closely with the department, with Optum, and with the provider community to work through the various ASO issues that Secretary Schrader summarized. COVID-19 also presents challenges with regards to providing services, particularly with in-person and residential services. With regards to access to services, which has been something that we've been focused highly on during the time of the COVID transition or experiencing this COVID pandemic, we've been working hard with our local jurisdictions to preserve our provider network as much as possible to meet the behavioral health needs of our communities, including the expansion of telehealth resources. It was noted about challenges with access to services. And I think that compared to many other states, Maryland has done a very good job maintaining the infrastructure of her behavioral health network compared to our neighbors. Based on provider surveys, we've seen an increase of 1,300% or more in the utilization of provision of services through telehealth. We have provided funding opportunities as whenever they become available to help the provider network, including the $10 million provided through DHCD from the governor for NORI funding for expenditures related to continuing to function during COVID, using SOAR funding for PPE to the tune of $2 million earlier in the pandemic, providing funding for crisis counseling, including our Operation Courage program for outreach for those who are on the front lines, and now the transition for the 988 implementation, which is going to go into effect in 2022. We remain committed to improving and looking after the quality of services that are delivered in the public behavioral health system. We're working with Medicaid, the ASO, and our providers to review and implement additional quality measures, such as enhancing the medical necessity criteria or enforcing the medical necessity criteria, particularly for PRP programs, which went into effect in July of 2020, implementing quality system and offering additional training opportunities to our PRP providers, reviewing the COMAR 1063 regulations and identifying opportunities for quality enhancement, and reviewing our payment structure, namely for our PRP programs. Local management, we continue to rely on our local behavioral health authorities to identify opportunities for quality enhancement we rely on our local behavioral health authorities as local managers for behavioral health services, for monitoring service and provider issues. We are focused on behavioral health equity is something that we've been looking at more closely since about June of this past year. We are glad that we will be leading the Lieutenant Governor's Racial Disparities Work Group on opioid death disparities. We are working to improve outcomes for all Marylanders, and we do know that you can't do that if you don't have a lens for equity. Regarding some new things that we are also doing, we're looking at improving and enhancing the crisis services that are delivered and available to Marylanders across the state, working in partnership with the Lieutenant Governor's Commission to Study Mental and Behavioral Health, Crisis Services Work Group, and many other stakeholders to identify the best model for the state of Maryland. If we look at our emergency room utilization data, it reflects that people in crisis are using the emergency department at pretty significant numbers, much more so for mental health services than substance use services. However, we realize that emergency room services are very, very expensive and also not the best place to receive care. So this is something that we're very much focused on. We believe that by having a more integrated response system, we can help to decrease this emergency room utilization and therefore have more appropriate utilization of public dollars. With regards to the COVID-19 pandemic, we have worked very hard to address the increases in stress, anxiety, and depression, as well as opioid overdoses over the past year, working through the Behavioral Health Administration with our partners, our stakeholders, and other state agencies. We've recognized the urgency of providing a coordinated response by doing a number of things, including providing training. We've been really focused on the mental health of the front line, and particularly those who are in the healthcare space, recognizing that those who are providing medical care during this time are healthcare or frontline services in any capacity are at increased risk for all behavioral health escalations for depression, anxiety, and substance use and suicidal ideation. So we've been providing training through the MDPCP webinar series about behavioral health resiliency for the provider community, as well as the behavioral health challenges that they need to be more mindful of when they're delivering services in the primary care workspace. We've most recently started a behavioral health webinar series called Helping Our Helpers in partnership with MedChi, which is open to all healthcare workers across the state, focused solely on resiliency, again, so that we don't have instances where we have our healthcare workforce feeling overwhelmed to the point of suicide, as we have seen in other states in the nation. And we've also been working through the Maryland Institute for Emergency Medical Systems. We create and supported through them a partnership to deliver services to those who work in nursing homes, also for similar reasons, to prevent the emotional exhaustion that comes from working during COVID-19. And so providing services on site through telehealth or group services to help with crisis management, stress management, time management, grief, to help support that part of the workforce. And that's just a small token of some of the things that we've been doing to try to support Marylanders during the time of this pandemic. I appreciate the opportunity to highlight some of our initiatives, and I can respond to any of your questions or concerns that you have at this time. And certainly we are more than happy to dialogue with you jointly or separately at another time. Thank you.
Thank you very much. And I know there are other representatives from the agency who are here. I don't know if they had planned to speak or just available for questions. Mr. Secretary.
Madam Chair, just for questions, in the interest of time for the committee, we'll stop our comments there and turn it back to you, and we'll answer any questions.
Okay, we do have questions. We'll start with Delegate Young and then move to House Chair Resnick.
Thank you, Madam Chair. And I know that my colleagues have some questions, especially with some of the information that was provided earlier. I've been waiting for this hearing for a bit, so forgive me, this kind of jumps off a little bit, and Secretary Schrader, choose whoever from your panel would best be suited to answer. So I just want to make sure that we're understanding that with the passage of the HOPE Act and other legislation addressing the challenges with the opioid epidemic, that we're meeting the requirements associated with those bills, that we're taking the 3 approved and other approved medication-assisted treatments, and that we are educating and providing what's needed to our providers so that we are treating, we're using the ability to treat our patients not in one way, but multiple ways have already been approved, so that we're not just using one form, which is how we got into the opioid epidemic in the first place, but multiple forms of treatment that have been approved. So I want to make sure that we're meeting those requirements, and if somebody could comment on that, please.
We definitely have been continue to support and encourage the use of all evidence-based treatments for the treatment of opioid use disorders. We have worked very closely with all of our opioid treatment programs throughout the course of the pandemic to ensure that they were open and available to the community. We probably only had one program that was not, that did have a period of time where they weren't operating, and that was not a private provider. And so we have done all that we, and also we have supported the use of telehealth, making it easier for people to access treatments like buprenorphine and naloxone, which they did not have to go on site to receive. But methadone, obviously, what we have been able to also support the waiver, the blanket waiver for methadone, so that patients didn't have to come in as often in order to stay on methadone and to prevent relapse. So we have certainly been doing what we can to ensure people continue to have access to all treatments for opioid use disorders. And we've also been meeting with all of our providers who provide opioid treatment services initially on a weekly basis. And at this point, we're still meeting every other week and have been since the onset of the crisis.
Thank you very much. I appreciate it.
Thank you, Delegate. Okay, so we'll go to House Chair Resnick and then Vice Chair Delegate Valentino Smith.
Thank you, Madam Chair. I have 2 lines of questioning for the department. First one returns back to the ASO issue in Optum. Exactly a year ago, we were sitting here in person in Annapolis, talking about the crisis that we have with the ASO, the inability to pay, and how, when we were told, if I recall correctly, that you are working on these issues and that by, I believe, summer, this would be worked out. We are now a year later, and Mr. Acting Secretary, I believe you just said that we are working on these issues and we expect to have them worked out at some point. I believe that's a paraphrase of what you had just said. I'm glad you think that everything's going well. I have not heard that from anyone other than from the department. We have hundreds of millions of dollars that have been distributed that we assume to be overpayments. At this point in time, given how small many of these providers are, and I granted the majority of them go to the larger providers, I understand that from Mr. Garrison's presentation, but there are still numerous providers that are very small, have limited budgets, and do not have the capacity to, the financial capacity to reconcile all those payments. We may potentially end up losing as a state a significant chunk of money in the hundreds of millions of dollars. There's issues with underpayments, potentially with some of the very same providers. And there are literally providers that have not yet billed a single dime for all the work they are providing to their clients because of all of these issues. It's been a year. It's been over a year since Optum took over. I understand that a lot of the blame went on to Beacon previously, and we're now a year plus into that, to the new contract. And I don't see how we can continue to do that. I want to know exactly where we are. And frankly, I want to know what liability Optum is assuming in all of this. And when, if ever, we're going to see a change of this contractor. How bad does it have to get before we see a change in this contractor?
So if I may, Mr. Chairman, I think if I respectfully offer that you've conflated two things. When we talked to you last year, we said we would fix the system and we would be paying by the contractors or the providers by the summer. That was done, and the providers are now being paid, and we stopped estimated payments in the second week of August. The challenging part here, and we're trying to be sensitive to the providers, is to go slowly so that we are careful about how we reconcile and working with them so we're not pushing them. But the actual process of paying claims goes on every day, and the system is working, and it pays it was $30 to $35 million a week with the prior incumbent, and it's $30 to $35 million a week now. So there are two different issues here. We did deliver on the commitment in the summer, and I'd like to be going faster, but I'm also concerned about the providers, making sure that we are very deliberate with this, with this $250 to $300 million that's got to be reconciled.
So how did we go from 255 million 3 months ago to 300 something million in overpayments when advance payments were stopped last summer? So
I'm going to turn to Corey Carpenter, who's been overseeing this, and he may end up asking Chad Burkholder. Corey, if you could answer that question.
Subcommittee Chair, respectfully, the difference between the 225 in the JCR and the approximately 300 right now, the 225 was an estimate at the time of what we would expect to remain after reconciliation. There was a time period between go live in the second week of August and us reconciling the claims that were submitted during that time period against estimated payments. So some of those claims paid out as new day claims, meaning that they could not be applied to the outstanding balances. There was also some adjustments that had to be made based off of tax IDs and national provider identifiers to account properly for where the estimated payments should be applied to based on several large organizations. And so we are continuing to work down and drill down into that amount. And as the Secretary mentioned, having an independent accounting firm would help make it abundantly clear what payments went out the door as new day claims as opposed to being applied to those balances.
And how much would it cost us to hire an independent accounting firm to reconcile $300 million of overpayment and dozens of million dollars of underpayment?
We are currently working through that process now. There are quite a few accounting firms that do a lot of work, especially with Medicaid, both here in the state and outside of the state. So we are looking at that, and we have some idea of rates, but we would have to put the question to the firms to get their analysis and their estimates of how much that would cost.
And how much of that cost is going to be picked up by Optum?
Yeah, I'll turn that over to the
Yeah.
secretary.
The intent is to use our developmental design money. And so that we've held back half of that money, and the intent would be to use that money, which would have gone to Optum, but would be used for this purpose.
Okay. My second line of questioning has to do with the 8507 program. I know that we have talked in meetings about this program. So I just have two questions about that program. The first one is with regard to grants in the relief package that we're going to go to the 8507 program. Has that money been distributed yet? The grant's been distributed, and if not, is there a criteria set up for distribution? Have you engaged with the provider community on how those grants are going to be distributed? Can you talk to me a little bit about that program?
Yeah, so we have not made any distribution yet. However, we are working on determining what the amounts are going to be based upon previous bed days for different providers at different levels of service, so that we are giving out the money proportionately to how people would have earned the same amount of dollars. So it's going to be, we are going to have an application, but just so that we can get the information that we need to put the money out. But we're making the determination largely from a formula based upon utilization of services previously.
And you've engaged with the provider community on this, and they have buy-in on this?
We will be engaging with the provider community. We're still coming up with a plan, formulating a plan, and then we can share that with the provider community, with the 8507 programs.
Okay. And my last question dealing with the 8507 program is, based on the concerns that I raised in our private meeting, my concerns that the program has been depleted because of COVID and because prosecutions are not diverting potential defendants to drug treatment versus cutting deals, putting them back on the street, or sending them straight to jail. We have seen a significant depletion of the 8507 program. So knowing that we have a future, hopefully a post-COVID future, where this program is still necessary and needed, what are you doing to plan for the future of the 8507 program with either the providers who are there and hopefully will continue to stay there, or supporting those providers so that we have either the same bed capacity or presumably an even larger bed capacity for expanded need based on Mr. Garrison's analysis? Those issues are increasing. So what are we doing to provide for the future of this program?
So we are looking at any resources that can be made available to help provide support for those programs. We're grateful to the governor for the $5 million that he provided for the 8507 programs. We're also expecting that the federal government is going to be releasing funding for that we'll be able to divert to our provider community through our SAMHSA block grants. I'm looking forward to that. I have to, we are most of our providers, though they are having challenges, like most people in business are having challenges right now due to COVID-19. Fortunately, they are weathering the storm. Overwhelmingly, the overwhelming majority of our providers are weathering the storm because of business practices that they have put in place that have enabled them to attract other business. None of our providers are committed 8507 patients. They are all open to any and all referrals, and they are all doing a good job attracting these other patients in order to fill their beds. When you mentioned that there is going to be an increased need for services, I don't have any question about the increased need for services, nor do we have any intention, or do we desire to not have beds be available when people need them. And if there was a concern about there not being such availability, we wouldn't see that there's actually more people that are coming into this space to provide the services for residential services. And we do have a couple of new residential programs that are going to be coming online. So there is no question about whether there is a market for this space, but businesses do have to make the decisions that are necessary in order for them to function effectively during a time such as this.
Thank you. Thank you, Madam Chair.
Thank you, Mr. Chair. Madam Vice Chair.
Thank you, Madam Chair. I had two questions. Thank you for the presentation. It's kind of a little bit of a follow-up on the 8507 beds, but obviously representing Prince George's County, highly concerned about the fact that we're seeing a double in the amount of opioid deaths. And so what I'm looking for is, have you done an analysis of whether or not, you know, for the court systems asking for the 8507 beds, or are courts having a particularly more difficult problem finding 8507 beds than other jurisdictions that are handling the need for referral out to the 8507 beds? And is our jurisdiction particularly seeing a disruption in service because of a disproportionality of providers that are there in the community to treat? And, you know, what are we looking at here with respect to and are you having a plan to dedicate more resources to a jurisdiction that is seeing a doubling in the amount of opioid deaths?
Thank you for your question, Delegate. We were certainly taken aback and surprised by the increase in overdoses in Prince George's County as well. It's not historical for Prince George's County to have as many overdoses as they had. Sometimes these sorts of things are not predictable in terms of what is the one thing or the two things that contributed to an increase. What we are seeing is that since that increase during the summer, the numbers for Prince George's County are trending back down to more normal numbers for Prince George's County. Though of course they're going to remain elevated as long as we look in the rear view window the way that we have to when we're looking at opioid overdose deaths. Because Prince George's County historically has not had the same challenges with opioids in terms of overdose deaths compared to counties like Baltimore City, Baltimore County, Anne Arundel County, the infrastructure for opiate use disorders treatment is not as robust in Prince George's County as it is in some of the other counties. We have been working with, one of the things that we've done is we have convened an opioid overdose prevention strategy team meeting that has been meeting since about June of this past year, where we've been looking at spikes in overdoses across the state, involving all of the local jurisdictions, so that we can look at what providers are doing in response to opioid overdose deaths in their jurisdictions, share best practices, make sure that we are disseminating information from the state and other state agencies in as efficacious a manner as possible. That has been very, very helpful. Since we have been doing that, actually, over the past couple months, we have not had any of our rates of opioid overdose are undesirable for any of us. This is true. However, from a spike perspective, the way that we numerically quantify a spike, we have not had any of our states that have been in any spikes since October of 2020, which is fantastic. Not to say that there's not a lot of work to do. There is a lot of work to do. We are working closely with the local behavioral health authority in Prince George's County to provide whatever supports it is that we can. They do have some new initiatives that are coming on board through funding from the HSCRC for crisis services, which is certainly going to help a lot with some of the challenges there. And then we also know that there's more providers that are coming into that community as well.
So, well, I thank you. Thank you for the dedication of an opioid prevention team and following up on this. I mean, I know everybody's overly busy with COVID, but following up from this, I think my real question was, and had you done an evaluation, not of what the providers are doing there, but over what services are actually supported by the department that are there within the county. And so after this, we'll continue to follow up. I'm sure Madam Chair is very interested in this also. Madam Chair, if I may, just a second question.
Sure, but let me
Can I-
just jump in before you go to your second one,
Yes.
because I want to piggyback really quick and say that I know the county is working aggressively to make sure that we have inpatient and outpatient resources to deal with behavioral health and substance abuse issues. And I'm sure you're aware of efforts to work with local hospitals in the county to build the infrastructure that you've talked about that we so desperately need. So thank you for raising that, Madam Vice Chair.
Thank you.
I'm sorry, can I just say one more thing? You mentioned about the services that are available. One of the things that the OOCC has done is they've created an inventory of all the services that are all the interventions across the state to deal with the opioid epidemic. We actually have about 129 different things that we do across the state to try to combat the opioid epidemic. And what we've also done is looked at that by jurisdiction and by region. So as we take our strategic opportunities for expansion of services and the utilization of funds through the Behavioral Health Administration, we look at the services that are missing in the various counties to help inform which types of programs do we want to bring to different, or do we want to support, or do we want to be more aggressive about supporting bringing to various jurisdictions across the state.
Well, thank you for your dedication to the issue. Obviously, you realize the extent of the problem. As a follow-up question, this might be for Secretary Schrader, I'm not sure, talking a little bit about the IMD services. So I did send off a letter to Deputy Secretary, we call him Webster, to Webb the other day, talking a little bit about concern for reimbursement and where the budget stood for reimbursement of IMD providers. And I understand since then that the providers have been in discussion with you and been assured that they'll continue to receive the reimbursement that they need. But going forward, do you have a plan or a strategy to reclassify the providers and seek CMS approval for them so that it's not all state money and that you have an opportunity to get some matching federal money for their services?
Yes, we have been asking on a number of occasions for CMS, and they have, we've even recently made some inquiries. Our Assistant Medicaid Director, Trish Roddy, is very skilled at this, and she's been working on it for several months now. We continue to get negative responses from CMS. That doesn't mean we're going to give up. I think the challenge for the IMDs, and it's unfortunate, and I know in the Lieutenant Governor's Commission that, a long time ago, the IMDs were viewed as a bad thing and we emptied them out. And now we understand that there's a need for some level of IMD, but the federal rules have not kept pace with that. So we're going to continue down that road. The other challenge in Maryland is that the hospital system does a good job of helping through the global budget, the GBR. If you're an acute care hospital, they've been able to weather this turbulence, but it's particularly hard on the IMDs because they don't get a similar consideration. So we're having the conversation. I wish it was something that we could move faster on, but we have got a pretty calcitrant federal bureaucracy that is not likely to move quickly, but we're not giving up on this.
Thank you. And I know Ms. Roddy is probably extremely skilled at working with them. We do continually tout the power of our Maryland federal delegation, and particularly with the change in administration. And so hopefully working through their offices, maybe CMS will respond a little bit faster.
Yes, and in the affirmative, hopefully. So thank you.
Thank you.
Thank you. I had Senator Eckert for the final question for this panel. Nope, you're good. Question asked and answered.
I'm good. I'll take it offline. Thank you. We may hear from the providers community, the advocates. Thank you.
Same. Well, Mr. Secretary, to you and your panel, thank you. I know that you, Mr. Burkhalter, others, Webster, have been meeting with Chair Gazone and I. So we share the concerns about this reimbursement and the process that providers will go through. So we look forward to continuing those conversations during session offline. And I'm sure that's consistent with where Senator Eckert was going as well. Colleagues, we have 12 witnesses signed up. So what I thought I'd do is call them in groups of 4 so that if you have questions, you're not having to hold them till we get all the way to the end. Does that make sense? Okay, seeing no objections, we will hear from Lori Doyle and Seacott. I'm going to apologize in advance and just say, Mr. Teal.
Yes, Subramaniam Palea Teal.
Thank you. I was going to try it. I had even written it out, trying to go phonetically, and then I said, no, I don't want to do that. So thank you for sharing that with me. And then we will have Sandra Trannon. So we'll start with Ms. Doyle, Ms. Seacott, Mr. Teal, and then Sandra Trannon. You may proceed. Good afternoon.
Thank you, Chair Griffith and Chair Resnick. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And I want to start by thanking the budget subcommittees and the General Assembly for your support of the rate increases for community behavioral health providers through the HOPE Act and then the minimum wage legislation. And also thank Governor Hogan for accelerating next fiscal year's rate increase of 3.5%. So we would just ask that you support full funding of this budget, including the continuation of that 3.5% for fiscal year 22. This has been a very, very challenging year because of COVID, but also because of Optum. And again, thank you to the subcommittees for keeping the Optum issue on your radar. And many of you interceded individually on behalf of providers in your jurisdictions, and we thank you for doing so. Unfortunately, the last time when we had the briefings before these subcommittees in last November, the system is still dysfunctional. And I think a lot of that dysfunction was outlined in Mr. Garrison's analysis. We did a survey recently of our providers, and we found that there's about $60 million in outstanding receivables. So we're concerned about moving forward because it seems like every time Optum fixes a problem, 2 more things break. But we're also concerned about the reconciliation process, and there's been a lot of talk about that. Of course, the number keeps increasing. We've been urging that an independent and neutral third party provide oversight and mediation between Optum and the providers. We think Optum ought to fund it, and we think that this reconciliation oversight entity ought to be reporting back to the budget committees on a quarterly basis as to the status of reconciliation. So we were interested to hear Secretary Schrader's remarks in that regard. The only other issue I'll touch on is about the psych rehab programs, the PRPs. We as providers have no desire to have inappropriate utilization of PRPs or any other service or any substandard providers because it paints all of us in a negative light. But we are concerned about an indiscriminative approach that might harm quality providers as well. We would note that Optum had particular difficulties in dealing with PRPs. They are paid on a monthly case rate. Providers submit encounter data until they hit a threshold, and then they can drop a bill. Those encounters were lost in the Encato Optum system. The encounters were inappropriately denied. There's a lot of manual processing and errors going on. So it may not be that kind of overpayment that's suggested by the data. It could very well be a lot of lost encounters that cause providers to get paid less than they should have. And I'll just close by saying that, our experience and Mr. Garrison's analysis makes it very clear that Optum's dysfunction makes the data suspect, and that any conclusions that are drawn on that data are questionable at best. So we ask that you take any action that you can within your power to hold Optum accountable, ensure that providers are not unfairly penalized for their shortcomings. And with that, I'll stop and thank you for your time.
Thank you. And Seacott.
Thank you, Madam Chair, members of both committees. It's good to be here. I'm Ann Seacott, representing the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We would like to express our support for the budget. We thank the governor for speeding up the legislatively mandated reimbursement rate increase that would have happened this coming July. We thank you all for your support over the years for making that happen as well. Given the struggles of the public health, behavioral health system since the start of the year, we know that the early start to that rate increase has been very helpful to providers. And we know that they've been dealing obviously with everything with the pandemic and having to rearrange all of their services, an increase in need, and the problems that you have been and will continue to hear about this afternoon about the failure of Optum. We need to look to where we go from here as well. The state must invest more in recovery support services, including peer counseling, relapse prevention, and housing. We thank the legislature for the additional funding you all put in the Relief Act for crisis services as well. We need to make sure that that support is ongoing and that those services are ongoing. We need to also make sure that we are doing what we can to make sure that crisis services are available to people when they need it, where they need it, when they're ready for it, and do our best to make it absent law enforcement presence and intervention as well. It speaks to some of what you all have been talking about with 8507s in terms of diversion, but even before we get there. And the big issue for us right now is that every time someone overdoses, it is treated by law enforcement as a crime scene. And until we get to the point where these scenes are really seen as an intervention for health as opposed to law enforcement, we are going to continue to lose people close to us. You've heard the data about the tremendous increase in overdose deaths. And I think that it speaks to our need to look at perhaps new and different ways of looking at things in terms of harm reduction approaches, as well as some of the crisis and the long-term recovery supports. So we thank you again.
Thank you. Mr. Teal.
Good afternoon, Chair Griffin, Chair Resnick. My name is Subramaniam Pillai Teal. I'm from Leading by Example. I am the clinical director as well as co-founder of Leading by Example. We are a community-based behavioral health company who's been providing community-based and in-the-home therapeutic services for the last 10 years. And my position is I support full funding for the behavioral health budget. As well, I'm here to advocate strongly to hold Optum accountable. We've heard many challenges and issues from providers that speak to our need to hold Optum accountable, but I want to offer to the committee a very real experience that my program is having right now in real time, which connects directly with a sensational question that Chair Resnick asked to Mr. Garrison, which was, what is the reason why the amount that's owed by providers is going up when the estimated payment stopped 8 months ago? And so I have a real experience. We run a program which is not provided by many providers at all. It's called the Therapeutic Behavioral Services Program. It's an intensive in-home behavioral modification program that's for children specifically who either have been hospitalized frequently within a year, at risk of going back to the hospital, or it's a service that's used for when young people are transitioning out of hospitals and residential settings to help them transition back in the home, to teach the caretakers how to take care of their children with these unique and special issues, and to prevent the young person from going back into residential care or into a hospital setting. We've been providing that service for about 10 years now. Again, we're one of very few providers that provide it, and we're not a large provider, we're a small provider, and we provide that service because it's connected to our ultimate vision and goal, which is to be a grassroots community-based organization that goes places that many providers are unwilling to go. So that service has been rate set at about $25 an hour for years. The rate was so low for that service that we could barely pay our workers minimum wage to do that service because it requires a clinician to also supervise the work that's happening. So in March of 2020, this is at the start of the pandemic, there was an official and formal fee schedule released by Optum, which increased that rate from $25 an hour to $75 an hour, which was most appropriate, specifically considering the requirements for that service and that we were in the midst of a pandemic. On March 1st, we raised the compensation rate for our counselors, which was a hallelujah celebratory moment for our organization and the community. We used those funds to outfit our workers who were going and continuing to go in the home face-to-face through the pandemic, because therapeutic behavioral services was one of the very few service lines that was not approved for telehealth. So you had to do that service face-to-face. We did that, and we worked with Optum directly to reconcile the payments from January to March. So they gave us the difference in what they underpaid us from January to March. And from March through June, they continued to pay us at the newly established, formally published rate. July 1st, Optum released a corrected fee schedule, what they called a corrected fee schedule for TBS, which then took what was $75 and backed it back to $50. They contacted our organization directly, and they shared with us that they were going to recoup and retract the money that they had already officially published as the rate. They were going to retract that from our future billings to the tune of $290,000. Delegate Resnick, this is directly connected to the question you asked. How is the money owed to you guys going up while the payments have been, we've been finished with those estimated payments? And the answer Mr. Garrison gave is stuff that seemed to be approved apparently is no longer approved. We attempted to reach out to MDH, BHA to resolve this matter amicably and reasonably. We sent the letter, we never got a response. We've been working with Ms. Lori Doyle and Shannon at CBH in order to try to get some advocacy efforts, because we're not a large program. This is a potential debilitating blow to us. We would be walking with a limp right now, going forward to provide services if that money was retracted from our future billings. Shannon and Lori reached out. They did get a response from MDH, and the response that they got was that leading by example should have known better. And that's where we're settled right now. So I'm continuing to advocate. I want this committee to be fully aware of this issue. It's active and ongoing right now. And I'm advocating again strongly to hold Optum accountable.
Thank you very
so
much.
for your time.
We'll go to Sandra Trennan.
Thank you, Chairs Griffith and Resnick and members of the committee. I'm Sandra Trennan. I'm the Executive Vice President at Partnership Development Group. We provide behavioral health services throughout Central Maryland. And our organization serves about 1,200 people every year, and we have 55 employees. So we're relatively small. A majority of those we serve are Medicaid recipients, and I'm here today to urge support for the Behavioral Health Administration's budget, and also to ask that you hold Optum accountable for its poor performance. Again, I want to thank you for support of community provider rate increases tied to the passage of the minimum wage bill, and also thank Governor Hogan for accelerating the fiscal 22 rate increases starting in January. These certainly help providers weather the combined storm of the pandemic and the implementation of Optum as our ASO. On to Optum. Our experience of Optum is that basic business revenue management tools just don't exist. We can't run reports, we can't research claims, we can't reconcile payments in Optum system. So basically, all of our billing operations need to be completed manually. We estimate that 24% of our billing and management staff time is spent troubleshooting Optum's deficient system. And due to their system limitations and errors, we experience claims denials constantly. Most of these erroneous claim denials. Claims processing errors represent $153,000 lost revenue for us just in the period from August through December 2020. I would submit, as Ms. Doyle had suggested, that PRP claims, which are being highlighted by the department, are being processed manually. And so there are multiple points for error in Optum's system in terms of claims processing. When claims are denied erroneously or paid at incorrect rates, they have to be reprocessed and tracked. We have hundreds of claims reprocessed multiple times. Again, this may account for the increase in the amount owed to the state. This means that instead of managing billing for an agency that submits about 1,300 claims a month, our billing staff is managing a revenue cycle equivalent to an agency about 5 times our size. And now we're faced with a prospect of paying back supposed overpayments that were made during this estimated payment period. We manually reconcile claims from reports remitted by Optum, which don't match any of the receipts we've received from Optum, which still yet display different information that is in Optum's own claims processing system. In addition, Optum has launched 3 different reconciliation process attempts, none of which have provided the tools and data needed by providers to complete reconciliation. From our perspective, a fair and accurate outcome to the reconciliation process seems unlikely. As a provider on the front lines of behavioral health care in Maryland, we urge you to act now, both to preserve Maryland's treatment capacity through supporting the budget and holding Optum accountable. Thank you so much for your time.
Thank you very much. Are there any questions for these 4 witnesses? Okay, seeing none, thank you all for coming and sharing your testimony with the subcommittees this afternoon. We're going to turn to Kelly Savoca, Chandra Chester, followed by David Benna and Ann Geddes. Good afternoon.
Good afternoon. Good afternoon, chairs and members of the subcommittees. I'm Kelly Savoca. I'm the Chief Financial Officer for Sheppard Pratt. I'm grateful for the opportunity to be here today. Sheppard Pratt serves more than 70,000 people at more than 380 sites throughout the state of Maryland. We have seen the COVID pandemic intensify the need for quality and timely behavioral health services. As a safety net provider, Sheppard Pratt proudly provides services to the state's most vulnerable. We have seen rising inpatient utilization by Medicaid consumers, both because of the increased Medicaid enrollees as well as an increase in demand. As Delegate Valentino Smith mentioned, related to the IMD funding, we were reassured by the administration that there was no IMD cap and this year's services would be fully funded. We're grateful for the short-term solution and we continue to seek a long-term plan related to IMD. And I was glad to hear the conversation with Secretary Schrader today, and it's certainly our hope that the department will follow through and keep pressing on the IMD designation. As an outpatient and community provider, the recent rate increases, including the accelerated 3.5% that went into effect on January 1st, allow Sheppard Pratt to maintain access to services amidst an epidemic. We are grateful for the support and request that the committee maintain this funding. These rates help offset the myriad of challenges that we face as a provider, cost pressures around staffing, virtualizing services during COVID, as well as the challenges that we are experiencing with the ASO transition. Then we appreciate the support of the Maryland Department of Health and the committee during this long and challenging process. Not really to belabor the issue, I think from our perspective, the biggest concern remains cash flow concerns. And it's already been mentioned several times today that the overpayments from the estimated payment period are really only part of the equation. Underpayments to Sheppard Pratt as a large provider of behavioral health services are significant and grow on every day as time goes on. So, really appreciate the committee's continued support for services and certainly we support full funding of the Behavioral Health Administration budget. Thank you for allowing me to speak today.
Thank you. Chandra?
Hi, good afternoon, Madam Chair, Chair Resnick, and members of the subcommittee. I'm Chandra Chester, and I'm the Vice President of Families First Counseling and Psychiatry. We provide behavioral health services in Montgomery County, Prince George's County, Howard County, Baltimore City, and Baltimore County. We employ about 117 individuals and serve almost 5,000 clients every year. Most of the clients we serve are publicly funded Medicaid clients. The pandemic has introduced major challenges for clients we serve. We thank Governor Hogan for accelerating the fiscal 2022 rate increases of 3.5% to start us out in January of 2021, as well as the General Assembly's support for behavioral health funding. These rate increases have been vital to helping us expand our telehealth programs rapidly and maintain our capacity to provide treatment. Unfortunately, these investments have been undermined by underpayments, higher costs, and system instability associated with the switch to Optum as an ASO vendor. We have had to hire additional temporary and permanent staff to manage manually driven claims processing under Optum. Optum's claims and customer service systems simply do not work. A few examples are Optum's claims processing is a hit and miss game that drops a large volume of claims to manual processing, which introduces a high level of error. Optum will deny claims for a client who they say did not have active coverage at the time of service, but will pay a claim the next day for that same client within the same date range. Whether a claim gets paid seems to depend on who processes it, rather than an automated system that processes all clean claims. We have thousands of claims that Optum has reprocessed 1, 2, 3, and sometimes even 10 times as it corrects its own errors. Optum's denial and adjustments codes do not follow industry standards, so we must manually reconcile each claim's reprocessing rather than being able to use our electronic medical record. Optum's system is just unreliable. For example, a few weeks ago, we lost the ability to download authorizations for 2 weeks. Our entire workflow stalled and backed up. Optum's clean denials often do not have accurate or actionable denial reasons, requiring us to call for an explanation. The length of an average phone call with Optum lasts about 45 to 60 minutes and fixes only a handful of claims. We also often get different answers every time we call, depending on who you talk to. The switch to Optum has had a negative impact on Families First financial stability. This situation is unsustainable both financially and for our overworked staff mentally and emotionally. We urge you to act now to preserve Maryland's treatment capacity through supporting the behavioral health budget and accountability for Optum. Thank you for your time.
Thank you. David Benna.
Good afternoon, Madam Chair and members of both committees. My name is David Benna. I am the Director of Catholic Charities Behavioral Health Clinic in Allegheny County. Our office is one of 6 Catholic Charities Behavioral Health clinics throughout the state of Maryland, providing counseling, psychiatry, and PRP services. In our county alone, we work with almost 700 adults, children, and entire families in need, providing care for individuals suffering from mental health disorders, life stressors, and substance use disorders as well. We strongly support the work of the Behavioral Health Administration and urge the full funding of their budget allocation. However, I wanted to bring up the ASO issue that you've heard from many others. You've heard a lot about the billing issues with Optum, but our clinicians are just as frustrated as our billing office is. Since the Optum contract started, we have continuously had problems getting services authorized due to their website not working, their customer service representatives not knowing answers to questions and unable to help, errors admittedly made by Optum representatives. This has led to a question that we've had to ask ourselves as a clinic. Do we provide services knowing the possibility we won't get paid, or wait weeks for services to be authorized and hope that the individuals we're serving will be okay? I'll give you an example from our clinic. We had a client referred to our PRP services from one of our therapists. This is on 11/12/20, due to the urgency of their severe depression and their housing situation. The person was about to become homeless. We needed immediate help from our PRP service to prevent him from living on the streets. This is someone with a history of suicidality and severe depression. The authorization request we entered was 11/12/20 with Optum, and we listed it as an expedited request, which is an option on the Encato website. We were not able to get services approved by Optum for almost 2 weeks. Under previous ASOs, this type of service would have been authorized usually within 24 to 48 hours. Our clinic decided to start working with the individual prior to the authorization being approved or denied. We wouldn't stand by and just watch a man with a history of severe depression lose his housing because of Optum's delay. In doing so, we risk non-payment for services being rendered. Providing services without payment is how agencies go out of business. But waiting for authorizations jeopardizes the lives of our clients. Marylanders are not receiving the services they are promised by the state. Providers are constantly put in the untenable position of calculating the risk of providing services before an authorization is approved. Currently, we have over 700 authorizations that remain pending. Some are pending and approved. Just showing evidence that the website and the information is incorrect frequently that we're getting from Optum. Under one of these pending authorizations, under one client, I found one service that was authorized, 6 pending, and 1 voided, all submitted at 5:04 p.m. in the same day, supposedly by the same person. Just showing the website is still not working correctly the way it's supposed to be working. This is a recent authorization request. Optum has started very disorganized, and it remains, the only word I can think for is a mess. It's still a mess. Across all of our clinics, we have 6,938 pending authorizations. Some are approved and pending, so it's not to say that all of those are not getting paid for. Some are approved and pending, but listed on the website pending 6,938, which we're trying to work through and figure out what's going on. We appreciate any support you can provide in navigating through this process. And thank you for your time.
Thank you. Ann, am I saying it right?
Ann Geddes, yeah. Thank you, Madam Chair and subcommittee members. My name is Ann Geddes. I'm with the Maryland Coalition of Families. MCF helps families that care for a loved one with behavioral health needs by providing family peer support and navigation services. I'm here in support of the Behavioral Health Administration budget. It hardly needs to be said that because of COVID-19, we have every reason to anticipate that demand for behavioral health services will skyrocket as we return to a state of semi-normalcy. Numerous studies have shown significantly worsening behavioral health among the population. Maryland must be prepared to address this need, and funding for the Behavioral Health Administration must be a priority. While many behavioral health treatment services can be addressed with Medicaid-only dollars, BHA needs full funding to continue to support an array of auxiliary services that are not reimbursable by Medicaid. Crisis services, the Wellness and Recovery Peer Support Centers, Family Peer Support, programs designed for young adults, and components of substance use treatment, among a few, all are funded with state-only dollars. These services promote recovery and can keep people, both children and adults, out of costly emergency departments, inpatient beds, and residential treatment centers. And I want to say a separate word here about crisis services for children and adolescents. The most recent data report from BHA on the utilization of behavioral health services by children and youth in the public behavioral health system showed that nearly 12% used emergency departments. Almost half of these did not result in an inpatient admission, indicating that the visit to the emergency department was probably unnecessary. Emergency department usage is expensive to the state and can be traumatic to children and families, especially when a child lingers for days in the emergency department. The answer is to build out a crisis system designed to address the needs of children and families, which are different than those of adults. Other states have implemented such programs, which have shown great savings. BHA has been trying to put into place crisis services designed for children and families by piecing together various pots of money, some of which are short-term, but it is not sufficient to build a comprehensive and sustainable system. For this, BHA needs adequate resources. We hope that the legislature looks at this need and finds sustainable funds to support BHA's efforts. Therefore, we request full funding of BHA's budget, and I thank you for your time.
Thank you. That was my 4 witnesses. Any questions for these 4 witnesses? Okay, thank you all for your time and for your comments this afternoon. Colleagues, we will now turn to our final four witnesses. We have Dan Martin, Michael Oliver, Tony Torsch, and Michelle Livshin. Good afternoon.
All right,
Thank
good.
you all for your patience. You've been waiting a long time, as have those before you. So thank you so much.
And thank you, Madam Chair, Mr. Chair, members of the subcommittees. I understand that we're the last panel keeping everybody, and it's been a long hearing, so I'll try to be quick. First, thanks to Mr. Garrison for such a comprehensive overview of the BHA budget, for highlighting the increased demand for services as a result of the pandemic. Those of us in the field see it not really just as an increased demand, but really as a parallel pandemic. The mental and emotional toll of COVID-19 has become really clear. Record rates of Marylanders feeling anxious or depressed. Crisis hotlines are seeing a startling increase in calls. Suicides are ticking up. Overdose death rates are through the roof. And so a well-funded behavioral health administration and a fully functioning public behavioral health system are important now more than ever. So that's why I urge you today to support full funding for BHA. I want to thank Dr. Jones and her team at BHA for everything that they're doing to address the increasing demand. As you've heard, all the different projects that they have going on to increase access to crisis response services, medication-assisted treatment for people with opioid use disorders, peer certification programs, early intervention programs, public awareness, et cetera, et cetera, et cetera. Everything that they're doing is critical in our efforts to address the increasing demand and the behavioral health fallout from the pandemic. And so full funding for BHA is critical. But I would be remiss if I didn't also take the opportunity today to voice and echo concerns from the entire behavioral health community about the ongoing challenges with Optum. I use the word challenges, but that's a doozy of an understatement. It's been chaotic and destabilizing for providers. This is a situation that will be untenable in normal times, but it's particularly disconcerting at a time of skyrocketing demand for treatment. The state has managed many of these transitions over the past 20 years, and it has never been so disruptive. And as problematic as it has been for providers, it's really the public who suffers because of this. As Mr. Garrison notes on page 24 of his overview, these challenges appear to disproportionately impact the currently uninsured individuals seeking care, leaving fewer options for these vulnerable individuals. And so, the Maryland Behavioral Health Coalition, which we chair, which is a coalition of upwards of 100 organizations, mental health and substance use disorder, consumer organizations, family organizations, provider organizations from around the state, has issued multiple letters over the past year to the Department of Health and to Governor Hogan and to the legislature, just doing anything we can to highlight the continuing frustration. And so, in addition to urging full funding for the Behavioral Health Administration, I join with a lot of my partners in encouraging this committee to take action that will increase transparency and accountability around Optum and in particular, the reconciliation process. Thank you very much.
Thank you. Michael Oliver.
Good afternoon, and thank you to the committee for allowing me to speak. My name is Michael Oliver, and I'm speaking on behalf on the Maryland Association for Treatment of Opioid Dependence. MATOD is a provider and advocacy organization comprised of the majority of the state's 95 opioid treatment programs. Maryland OTPs currently provide comprehensive medication-assisted treatment to over 40,000 Marylanders with opioid use disorder. I'd like to start by thanking the committee and expressing our gratitude for the early implementation of the rate hike. It is incredibly important to providers. We support the full funding of the BHA budget and also holding Optum accountable. The Administrative Services Organization transitioned from Beacon Health Options to Optum Behavioral Health has placed an undue burden on the behavioral health community and opioid treatment programs specifically. At this very moment, NCATO still has a vast number of technical problems that negatively impact provider workflows. These technical problems include not just small issues that impact specific providers, but systemic issues that raise questions about the accuracy of the claims processing system. If it were not concerning enough that NCATO is not properly paying providers at this date, 15 months after initial implementation, providers are also being forced to do the work of verifying NCATO's claim information during the estimated payment period. This verification work is essential to ensure that providers were paid accurately or overpaid. to ensure only the correct amount is returned. This work was not the fault of providers, but we are left holding the bag, being forced to sift through this information with the implicit threat of money or services rendered being taken back by Optum. This requires providers to work countless hours, accrue increased expenses, and divert resources from the provider's primary focus, serving clients. Optum is reporting roughly $300 million owed back, but reconciliation hasn't even started in earnest. We are currently in the stage of reconciliation in which we are simply verifying that Optum has our claims from this period. We have not even begun working through incorrected denials that will inevitably reduce the amount owed by providers. In fact, Optum has warned against resubmitting these claims currently to reduce estimated payment period balances because the updates in the Encato system have not been implemented in order to accurately complete this task. Optum may be confident in the amount owed by providers, but no provider in Maytown feels comfortable with their determination. Maytown has been in consistent dialogue with Optum since January 1st, 2020 about the lack of effectiveness of the Encato system. Maytown has highlighted areas of concerns and missing data that is required for providers to effectively be paid for claims today, as well as account for claims during the estimated payment period. Maytown providers continue to find missing sets of data that make this work impossible. I thank you for the opportunity to speak with you about the ASO transition and would be happy to answer any questions you may have.
Thank you. I don't see Tony Torsch, so we'll go to Michelle Livshin.
Thank you, Madam Chair, Mr. Chair, and committee members for your dedication to improving healthcare services for Marylanders. My name is Michelle Livshin, and I'm representing Honor Own of Maryland. We're a statewide peer support advocacy organization operating for 25 years by and for people with lived experience of behavioral health challenges. Our network of 23 peer-run centers offer immediate choice-based recovery support services to community members with behavioral health challenges. In an average year, our network collectively serves up to 7,000 unduplicated Marylanders experiencing complex needs such as homelessness, having multiple health conditions, being uninsured, or with limited disability income. Our network is almost entirely funded through Behavioral Health Administration grants. During COVID, our centers have been providing comprehensive practical support for community members with the fewest resources and at the greatest risk for crisis. On the Lower Eastern Shore, our center partnered with the local food bank to distribute meals and toiletries directly to people's homes. Our Frederick Center leveraged community partnerships to distribute track phones with 2 months of data so members could stay connected to peers and treatment providers. In Howard County, daily phone calls help members be proactive, access resources, and feel that caring connection that can literally mean the difference between life and death. The Honor Known Network is a safety net for our behavioral health and human service systems. At our centers, people who feel unwelcome, unsafe, or are overtly rejected by clinical providers are able to get support with their wellness and recovery. For some, we are the only supportive service available and used. Our centers are an integral piece of the continuum of behavioral health services and by far the most cost-effective, often with a per-member cost of only $50 a month. Maryland faces an escalating behavioral health crisis alongside the pandemic. Calls to Baltimore Crisis Hotline have already doubled. Our network of peers stand ready to support our communities throughout this crisis, but we must have adequate resources and funding. We thank the legislature for its continued support and strongly urge the committee to support full funding for the Behavioral Health Administration's FY22 budget. Thank you.
Thank you, and thank you all for your testimony. Chair Resnick.
Thank you, Madam Chair. Less of a question, more sort of an ending statement here. I actually want to thank Mr. Burkholder for being on the entire time. I know he did not personally speak, but as Optum's representative, I'm glad he was able to hear all this. I know that in these kinds of situations, there's always two sides, right? There's always providers that make errors in their billing and end up, having to retract or rebill, and there's always errors on the payer side as well. But what we're hearing here is universal condemnation of the past 15 months. And so far, to the best that I can see, despite the department saying that everything is on track and everything is fine, everything is not fine. We need to see a massive change, and we need to see it soon. It's funny, I have been very agnostic about the debate that started up, I believe, a year ago or so about carving in and carving out BHA services. But unless something changes with Optum, I think Optum single-handedly is making a case that we need to move back to carve in Medicaid behavioral health provisions, because this cannot continue. And if either Optum, its subcontractor, or the department doesn't make a massive change in the next few months, I think we're going to have to take drastic actions between now and next session to fix this situation. Because right now, by my estimation, it's only getting worse. And I'm hearing from the providers. I know we're all hearing from the providers, and things are not improving. So please, Mr. Burkholder, please go back, work with the department, and figure out a solution that doesn't have us back here in several months on a briefing talking about how it's now $400 million, because I feel like that's the trajectory we're going into. Thank you.
Thank you, Mr. Chairman. That pretty much sums it up. Let me just thank all of the analysts and the members for your attention today, all of the witnesses. And I too thank you, Mr. Burkholder. I know it's not easy to sit and hear comments that are uncomfortable about the organization that you're representing. I know that we've been engaged in conversations all interim around these issues with the department and hearing different reports from different audiences. And so I think today we've all heard the same thing at the same time. So I would just echo the sentiments of the House Chair and say we all want the same thing, which is to get providers paid and citizens served. So let's look for how we can do that together. Thank you all so much for your time and attention this afternoon. We'll be together again in a few days. So everybody be safe. Have a good evening.